This is part 2 of my talk about diuresis renography. In part 1 I gave an introduction by reminding you what a renogram is, explaining pelvi-ureteric junction obstruction and discussing the possible investigations that we might use. Now in part 2 I'm going to talk about the principles of diuresis renography. In particular, I'm going to discuss kidney transit times and describe the effect of Frusemide on those transit times. So if we're talking about renal transit times, let me remind you of the system that we're talking about. Each kidney is made up of about 1 million individual nephrons, which are the functioning units of the kidney, located in the cortex and the medulla, which are together called the renal parenchyma. Each nephron starts off with a glomerulus, which is located in the cortex and the outer part of the kidney, and then the filtrate passes down through the tubules, which dive down into the medulla through the loop of Henle, back up again to the cortex before coming back down into the medulla, where the collecting ducts gather the urine together from several individual nephrons before they gradually drain down into the calyces and the renal pelvis. So that's the system that we're talking about. So let's look at how urine is formed in the nephrons. Now, as I've said, each kidney is comprised about 1 million individual nephrons, but for the purpose of this model I'm going to represent the kidney as if it was one giant nephron, representing all the nephrons summed together working in parallel. So this diagram illustrates what's going on in the two kidneys combined. Now we know that blood comes in through the renal artery and leaves through the renal vein, and as it passes the glomerulus, small molecules, which are mainly water and salts, are going to be filtered, and then the filtrate will pass down through the tubules in the proximal tubule, down the descending limb of the loop of Henle, back up the ascending limb into the distal tubule, and then through the collecting ducts down through the renal pelvis and eventually out through the ureter. Now the rate at which plasma enters the two kidneys together, the renal plasma flow, is about 660 mils a minute. But the rate of filtration of the two kidneys together is only about 125 mils a minute. That's the rate at which filtrate is going to enter the tubules. But we know we only produce about 2 mils a minute of urine on the average, so clearly a lot of that water has got to be reabsorbed. And understanding that is key to understanding transit times. Now we know that there are mechanisms by which sodium is actively pumped out of the filtrate in the descending limb of the loop of Henle. That will create an osmotic pressure difference because there's a greater concentration of sodium ions in the cells surrounding the tubules compared with the filtrate inside the tubules. That osmotic pressure difference will cause water to be reabsorbed passively because the water will try to follow the sodium in order to equalize the osmotic pressure. So the active sodium reabsorption is followed by passive water reabsorption. That will reduce the flow in the tubules until we get to the ascending limb. The flow is probably reduced to somewhere about 25 mils a minute. Now the ascending limb of the loop of Henle is impervious to water, although the active sodium pump continues there, so no more water is reabsorbed in the ascending limb. We have some more absorbed in the distal tubule, so by the time we get to the collecting ducts the flow is maybe about 12 mils a minute, but we get more water reabsorption in the collecting ducts, which reduces the flow to the 2 mils a minute that we see from both kidneys together in the actual urine production. So clearly the flow rate has been changing quite dramatically through the length of the tubule. So we can see that it's moving very rapidly, fast flow early on here, but as it gets further on, its flow gets slower and slower and slower until in the collecting ducts it really is quite a low flow. So if we look at the time it takes for water to get through the system, we see that the transit time early on through the tubules from here through to the beginning of the collecting ducts, the flow is quite fast, so that's a relatively short transit time. But even though the length of the collecting ducts is physically less because the flow is so low, the transit there is much longer. So it's about 40 seconds through the tubules and maybe another 90 seconds through the collecting ducts, making a total transit time of just over 2 minutes. These are approximate figures, don't take any account of the fact that actually some of the nephrons have different length tubules, and it does certainly depend on actual flow rates, but these are some typical figures. So how is all this relevant to renography? Well, in each nephron, and we know that the nephrons are within the parenchyma, so I've divided this diagram into the top half of the diagram, which represents the parenchyma. We said that water was filtered at the glomerulus, and the renal radiopharmaceuticals that we use, typically DTPA and MAG3, are going to be filtered because they're small molecules, and indeed MAG3 is also secreted. So by a mixture of filtration and secretion, they get added to the filtrate here in the proximal tubule. But then they're carried along through the kidney by the flow of water. There's no reabsorption of pharmaceuticals, so the time it takes the radiopharmaceutical to get through the tubules is just a measure of how long it took the water to get through. They're just really markers for the water passing through. So in the descending limb of the loop of Henle here, we've already said that we have active sodium reabsorption, which creates this osmotic pressure difference, and water is therefore reabsorbed passively. If we have an obstructed system with a high pressure in the renal tubules, that will increase the water reabsorption because that hydrostatic pressure will push more water out, in addition to what is absorbed by the passive reabsorption from the osmotic pressure. But when we give Frusemide, that inhibits the sodium pump and leads to the opposite effect. It gets less water reabsorption, and so we get a more dilute urine. Now the ascending limb of the tubule is impervious to water, as I said, but we still get sodium being pumped out there, and the collecting ducts, water reabsorption continues. But when we get to the renal pelvis, the radiopharmaceutical just mixes with urine there before leaving, so that's a rather different effect which we'll have to consider. So now let me say a little bit about Frusemide. The international name for this drug is now furosemide, but in the UK it was previously known as Frusemide. So that is the name that I have used in a lot of my illustrations over the years. So I hope you'll forgive me if I continue to refer to it as Frusemide in this presentation, even though I know that the international name is now furosemide. It's also available under the trade name of Lasix, so it's sometimes referred to as that. It's a loop diuretic, which means it blocks reabsorption of chloride and sodium ions in the thick ascending limb of the loop of Henle. And as we've seen, by reducing the absorption of sodium, it reduces the osmotic pressure in the peritubular tissues and therefore reduces the amount of water reabsorption that follows passively. That means there is more water left in the filtrate, more water comes out in the urine, we get a higher flow of more dilute urine. That's the diuretic effect, as we call it. So you have to realize that it reaches its site of action in the renal tubules only if it can get into the tubules, which it does by tubular secretion. So if we have a patient with reduced kidney function, or indeed in renal failure, then the effect of Frusemide will be reduced because it doesn't get into the tubules. It's well recognized that in patients with renal failure you have to give large doses of Frusemide to have any effect at all, and we have to bear that in mind during renography, because it means that even in poorly functioning kidneys we're not going to get as much Frusemide into the tubules, and therefore we might expect that the diuretic effect of Frusemide might be reduced in poorly functioning kidneys. It also has an effect on the renal blood flow. It does increase the blood flow to the kidneys slightly when you give frusemide, and that will produce a change in the renal uptake, but it seems to be balanced between the two kidneys. So studies have shown that it doesn't produce any significant change in the relative function between the two kidneys. So what we're interested in diuresis renography is principally its diuretic effect rather than its effect on the change in blood flow. Now let's just discuss the urine output. On average, we produce about 1.5 litres of urine over a 24-hour period. So average throughout the day, that would be 1 ml a minute, but it's going to be more during the day and less during the night. So let's assume that a dehydrated patient would have a urine flow of somewhat less than 1 ml a minute, and that a well-hydrated patient, which is what we aim for during a standard renogram, because we aim to the patient to have a little bit more than average urine flow, it's been shown that typically we get between 2 and 6 mils a minute. Now, after frusemide, given intravenously at 0.5 milligram per kilogram body weight, the urine flow increases quite considerably up to about 25 mils a minute. This is for the two kidneys together. We know the effect starts within 3 minutes, because if you give frusemide partway through a renogram, you can see it has an effect on the renogram very rapidly within about three minutes. But studies taken after frusemide, measuring the amount of urine produced, show that it peaks around 15 minutes. This graph is some figures from Steve Upstall's MD thesis, with the work that he did with us in Manchester Royal Infirmary, and you can see that we get an average figure of around about 25 mils a minute. However, that hides the fact that there are quite a lot of variation between patients. These are some of the individual patient figures. Some of the flow rates didn't start going up until some time after, and some were indeed coming down by 15 minutes. But on average, we get quite a significant increase in urine output. So when we need to look at some kidney transit times, we need to first of all think about the parenchymal transit time. That's the time to pass through the tubules, down through the distal tubule, and down the collecting duct through the parenchyma, which is where the tubules are located. Now, these are long, thin tubes, so there's really no mixing. The time it takes for a molecule of radiopharmaceutical purely depends on how much water is passing through, so it depends on the water reabsorption. And as I said, if you've got a high pressure in the tubules because of an obstructed system, that will increase the transit time because it forces more water out, and so the water takes longer to get through, and therefore the radiopharmaceutical will take longer. But frusemide has the opposite effect. It will reduce the transit time because less water is reabsorbed, so the radiopharmaceutical goes down through the tubules more quickly. When we get to the pelvis, it's slightly different though. This is not a long, thin tube, this is a large mixing chamber, so the transit time is determined by the volume divided by the flow. So if we've got a dilated pelvis, we have a large volume, which means we have an increased transit time. But if we give frusemide, which increases the urine flow, and that comes in the denominator of this equation, that means increasing the urine flow will reduce the pelvic transit time. So dilated pelvis and frusemide have opposite effects. The whole kidney transit time is the sum of those two. It's the total time to get through the whole of the kidney from through the tubules, the collecting ducts, and the renal pelvis. So what does all this mean for the shape of the renogram? Well, I've produced a mathematical model of the renogram using the estimates of flow rates and volumes and transit times that I've described. This is a model for a single kidney, so I've taken the flow rates that I've just discussed for two kidneys and halved those, but the transit times remain the same because that doesn't depend on whether it's one or two kidneys. Using this model, you can see how the shape of the Renogram curve is affected by Frusemide. So let's start with a normal kidney. Let's assume that each kidney has a volume in the pelvis of 5 mils, which is a reasonable volume for a renal pelvis, and we said that the urine flow rate during renogram for a single kidney is going to be about 2 mils a minute. So the pelvic transit time, 2.5 minutes, is got by dividing the volume by the flow. 5/2 is 2.5 minutes for tracer to go through the renal pelvis. The normal parenchymal transit time, I said, was about 2 minutes, so the total transit time, which is the pelvis plus the parenchyma, is 4.5 minutes. And if you model a renogram with a total transit time of 4.5 minutes, it looks something like this. You see it peaks around about 3 or 4 minutes here, and then comes down quite normally, and this is equivalent to a normal renogram. So this shows that the numbers in the model are reasonably realistic in that they're reproducing the shape of a normal renogram. Now, if we give Frusemide to this patient, it shouldn't change the pelvic volume, but it will increase the flow rate, and let's take it up to 10 mils a minute for a single kidney. So now the transit time through the pelvis is 5/10, which is 0.5 minutes. It will also reduce the parenchymal transit time because we've changed the flow in the distal tubule in the collecting ducts, and so it gets a little bit faster, maybe reducing it from 2 to 1.5 minutes. So the total transit time is 0.5 minute through the pelvis, 1.5 through the parenchyma, which is a total of 2 minutes, and that gives a curve like this green one, which certainly peaks much sooner, but still washes out normally. So the effect of Frusemide is to speed everything up. I also pointed out that Frusemide increases the renal blood flow, so we might expect it to increase the uptake very slightly, but the principal effect is to sharpen the peak. But what would happen if this patient was dehydrated, if they hadn't had sufficient fluids as we would normally expect for a renogram? So if the pelvic volume is still 5 mils, but they're dehydrated and I've got a urine flow of, say, only 0.5 mil per minute for each kidney, 5/0.5 is 10 minutes to get through the renal pelvis now in this dehydrated state, and it's going to be a little bit longer through the parenchyma as well because the flow is a bit slower, so a total of 13 minutes. And if you model a renogram with a total transit time of 13 minutes, it looks like this brown curve here. So you can see that a dehydrated renogram is very different to what we would hope for a normal renogram. So if you didn't know that this patient was dehydrated, you might misinterpret that renogram and think that it's either a large dilated system, which is where it's slow to empty, or you might even be tempted to say it's an obstructed system. But in fact, this is just the effect of dehydration. That's why we say that patients must be adequately hydrated before they have their renogram. If they're dehydrated, you may get the brown curve, which can be misinterpreted. We're aiming for the yellow curve, but if they've had too much hydration, all it will do is push them towards the green curve, which can't be misinterpreted. So it's important to make sure that patients aren't dehydrated when they have their renogram. And clearly the sort of time when you can get into difficulties is in a hot summer day. If the patient hasn't had sufficient fluids before they rush out to their renogram, then you may be in danger of having the brown shaped curve unless you make sure that they have had plenty of water before the renogram starts. The other favourite time for this is when the patient's been out on the town the night before, had a lot to drink, we got very dehydrated from passing a lot of urine and not had time to rehydrate themselves before they come for their renogram first thing the next morning. So those are things to look out for. Make sure that the patient is adequately hydrated, otherwise you'll get the wrong shaped curve from the renogram. But let's move on to a dilated system. This is a hypotonic pelvis, which is a large volume, is dilated, but it's low pressure. So if we look at the figures for this, let's assume that we have a larger volume, maybe 30 mils for the volume of the pelvis, but we still got the normal flow rate of 2 mils a minute. So through the pelvis it's 30 over 2, which is 15 minutes, showing it does indeed take much longer for the urine to get through this dilated pelvis. We still have a normal parenchymal transit time of 2 minutes, so the total transit time is 17 minutes. If you model a renogram with a transit time of 7 minutes, it's something like this, which, as you can see, is very similar to the brown curve I had before from the dehydrated patient. But if we give Frusemide to this patient, it shouldn't change the pelvic volume, but it will increase the flow rate significantly. Let's bump that up to 10 mils a minute. So the transit time through the pelvis is now 30 over 10, which is 3 minutes through the pelvis. So it has reduced the transit time through the pelvis back down to normal by increasing the flow rate. It will reduce the parenchymal transit time slightly, as I said before, maybe to 1.5 minutes. So the total 3 plus 1.5 is 4.5 minutes. And the renogram with a transit time of 4.5 minutes is the green curve that I've showed there. So the effect of Frusemide on this system with a dilated pelvis is to change it from the yellow curve to the green one. In other words, it makes it look like a normal shape. And when Paddy O'Reilly first started using this technique, he would first do a renogram and get a curve like the yellow one, and then bring them back on another occasion and give some Frusemide and repeat the renogram, and it turned into the green curve, and he deduced from that that it was just a low pressure, large volume system. But of course that meant 2 visits for the patient, and he soon realised that by giving the Frusemide part way through the first renogram, if we give the Frusemide here at 20 minutes, then we see a rapid change from the yellow towards the green curve, and the Frusemide, by increasing the flow rate, rapidly empties that pelvis, and the patient therefore only needed to come once. So the Frusemide given at 20 minutes produced a rapid washout, showing that that was indeed a low pressure non-obstructed system. But if we've got a dilated but obstructed system, this is a high pressure system, we've still got the same volume of the pelvis, say 30 mils, and the same urine flow rate for the standard renogram of 2 mils a minute, so we still got a large 50-minute transit time through the pelvis. Now the parenchymal transit time was normally 2 minutes, but if this is a high pressure system, then you might expect that if that high pressure backs up into the tubules, it will force more water out of the tubules, and therefore you will have a slower flow through the tubules and a longer transit time. So let's suppose that's 5 minutes instead of the normal 2 minutes. So the total transit time is 15 plus 5, which is 20 minutes for the total transit time. And if you model a renogram with a 20-minute transit time, it looks something like this. Now, that's not distinguishable from the 17 minutes that I had for the dilated but low pressure system. So from this alone, we can't distinguish the shape of the curve to say whether it's high or low pressure. But if we give Frusemide to this patient, let's suppose that it increases the volume somewhat, because if it's obstructed, the flow is going to be harder to increase, and it will increase the volume maybe from 30 to 50 mils. Now in the non-obstructed system, I let the flow rate go up to 10 mils a minute, but in this obstructed system, the high pressure is going to mean more water reabsorbed, and then we don't manage to increase the flow rate as much as that, so let's put it up to just say 5 mils a minute. So 50 over 5, 10 minutes, is now the transit time through the pelvis. The parenchymal transit time is already increased, so the total of 15 minutes gives this green shaped curve, which is really not very different from the yellow one. So indeed, when Paddy started this, he would give a renogram and produce the yellow curve and bring them back on another occasion and get a curve like the green one, saying it hadn't really changed very much with Frusemide. So the system clearly hadn't emptied with Frusemide. It's an obstructed system. So once again, he realised that by giving the Frusemide at 20 minutes, he could produce a curve that's got to go from the yellow to the green, so it only comes down very, very slightly, not the very obvious change that we got with the non-obstructed system. There are also systems like this, where you've got a pelvis which is perhaps somewhat dilated and perhaps a rather unusual shape, with a dependent bit of the pelvis here, maybe with the ureter coming out a bit higher up. So let's give this a moderate volume, say 10 mils, but with a normal flow of 2 mils a minute. We get 5 minutes through the pelvis, a normal parenchyma transit time of 2 minutes, give us a total transit time of 7 minutes. So the Renogram curve from that is somewhat slightly delayed in its peak because of the larger volume, but it's nothing spectacular. So I wonder what happens if we give Frusemide to this patient. You may just like to think for a moment what's going to happen if we try to increase the flow through this system, bearing in mind its rather unusual shape. Now, what can happen is that the volume doesn't change, but because the pressure increases in here, as the pelvis expands, it actually crimps off the pelvi-ureteric junction, so urine is not able to get out at all. It induces an obstruction at the high flow rate. So instead of the flow rate going up, it drops down dramatically, let's say to 0.3 mils a minute, which means the time through the pelvis is now 10 over 0.3, which is 33 minutes. The parenchymal transit time goes up a bit as well. So we end up with a total transit time of 38 minutes, and we end up with a curve like this that just doesn't empty at all. Now, to see that effect at its greatest, we have to wait for the Frusemide to take effect. So if you give Frusemide and then 15 minutes later start the Renogram, that's why I've called this F-15, because Frusemide is given 15 minutes before the start of the Renogram, you see this effect, and the Renogram is normal at a normal flow rate, that's the yellow curve, but with F-15, where you start the Renogram 15 minutes after the Frusemide, it's totally obstructed. So the interesting question with this is what would happen if you gave the Frusemide 20 minutes into the yellow curve. You were down here and now you give the Frusemide. Is it going to go down, go up, or what? Well, actually what happens is that after the Frusemide, it begins to try to come down as the flow rate builds up. It's beginning to empty, but when it gets to the point where the PUJ crimps off, it can no longer allow flow out at all, and so it goes up again. And this is known as Holmes's sign. A few minutes after the Frusemide, although the curve started to come down, it then obstructs completely and goes up again. So that's something to look out for, which is why you need to continue for 15 minutes or so after the Frusemide to be sure that you've not got Holmes's sign. So this is a system which obstructs only at high flow. At low flow it's normal, but at high flow it can obstruct completely, and that's a condition to look out for. So to summarise the transit times that I've just shown you in the last few examples, these are all the numbers that we've just been through. And for each one I've shown the result for the standard Renogram and for the Diuresis Renogram, and what we're trying to do is to distinguish diagnostically the non-obstructed system from the obstructed system. And if we look at these numbers, there's some things we can see. This number here of 15 minutes for the total transit time after diuresis shows that we have an obstructed system. The long transit time after Frusemide indicates that this is an obstructed system and a high pressure system, because the non-obstructed system had a normal transit time after Frusemide. But we can also see that this number here would be useful, because here this is the transit time from a standard Renogram without Frusemide compared with the non-obstructed without Frusemide. So this enables us to diagnose the obstruction without having to give Frusemide, because we're comparing two standard Renograms. So the 5 and the 2 minutes is a distinguishing characteristic of the obstructed system, but we have to look at the parenchymal transit time to do that. If you look at the total transit time, comparing the 20 with the 17, you can never distinguish that from the shape of the curve. They're far too similar. So this is the basis of using parenchymal transit time, which can be determined by deconvolution, in order to diagnose an obstructed system. But you have to use the parenchymal transit time. You can't do it from the whole kidney transit time. So let's compare those two techniques. Diuresis renography, which I've just described, is a technique where you only need to look at the whole kidney. You don't need a region of interest for the parenchyma alone. But you compare the renogram with and without frusemide, and it uses a visual analysis of the curves. And if you see that the kidney curve is slow to empty without frusemide, that says you've got a dilated pelvis, but it doesn't tell you whether it's a high pressure or a low pressure system. But if the kidney still does not empty after you've given frusemide, that says you've got an obstructed system, which implies it's a high pressure. On the other hand, deconvolution renography only needs a renogram without administration of frusemide, but you do need to compare the whole kidney and the parenchyma, so you need that additional region of interest over the parenchyma alone. And you can calculate the transit times by the mathematical technique of deconvolution, which I've explained in detail in another talk in this series. And if you find you've got a long whole kidney transit time, that tells you you've got a dilated pelvis, but it doesn't tell you whether it's high pressure or low pressure. However, if the parenchymal transit time is also long, that tells you you've got an obstructed system, which implies it's a high pressure. So the two methods of renography are alternative techniques for diagnosing whether you've got an obstructed system or just a dilated pelvis. The diuresis renography means you have to give frusemide, but you don't need to do the region of interest over the parenchyma. Deconvolution means you have to make the region of interest over the parenchyma, but you don't need to give any frusemide. So each of the techniques has its advantages and disadvantages. So that's the end of the second part of this talk. In part 3, I'll go on to explain the practicalities of performing diuresis renography.